Dr. Lazar, welcome to the Wellness Lab. Pleasure to have you.
Thanks for having me.
Yeah. So so the viewers know, what's your work in the clinical space? You're a clinical psychologist. What's your work been in that so far?
So I'm a clinical psychologist in private practice, and my primary caseload usually consists of people who are suffering from anxiety, suffering from depression, some folks who are suffering with psychosis, and I approach those from a cognitive behavioral therapy angle.
Okay. And so the topic I wanted to get into today with you was OCD, just to kind of give everyone an overview what this is, what it isn't, and how to dismantle that, and then how you might treat it. So just so everyone's on the same page, how would you explain OCD to someone who is a beginner in this space?
So OCD, it's sort of an anxiety presentation, although sometimes it can sort of fall under some other umbrellas as well. But it's often when people have thoughts that they kind of perceive as intrusive. And that's sort of what the obsessions are. So somebody might, be driving down the street and they go over a speed bump and just out of nowhere, the thought pops into their head, what if I just ran over a person? As an example. And of course, you would imagine as you have that kind of thought, you get quite anxious as a result. And so typically when we become anxious, it engages our fight or flight response. And so we want to alleviate that distress. And so often then people will engage in a behavior or do some kind of compulsion to try and reduce that anxiety. So an example I gave, the person may sort of drive, come around the block, check just to make sure there's nobody lying in the street, or that was in fact a speed bump that was there that they noticed. And then that brings the anxiety down and they typically feel better.
And it sounds like the distinguishing factor there is someone who doesn't have this disorder, hits a speed bump and just thinks speed bump and continues going. And the distinguishes how much that gathers their attention and how that thought just comes unprompted. And that sounds, yeah.
People often experience it as very like the technical term they use is like ego dystonic. So it's sort of it feels like it's not sort of part of your thought processes in some way. Like it kind of feels like why would I think that? So it's different than something where you're worrying, like which is more sort of maybe part of your everyday experience. Like if you're worrying about being late or you're worrying, driving too fast or getting a ticket or something like that. This kind of feels like it almost just comes in and it's sort of, what was that?
Yeah. I've heard just in conversation and people I know with OCD who describe it as they're a victim to their own thoughts. Does that feel like a good way to phrase it in your experience?
Yeah, it's an interesting phrase actually. Yeah. I mean, I think a lot of people, the way they sort of recognize that it is their own thought processes
Mhm.
and it creates so much distress, but it's also really hard to let it go. So for people with OCD, they'll kind of go over that speed bump and that thought will just keep repeating over and over and over again. And it causes a lot of distress. And even sometimes when people would say, like, I kind of know that it's not accurate, they still sort of find themselves compelled to kind of engage in that behavior, which can be very frustrating and also very impairing because, if you're spending a lot of time, you know, doing various behaviors to kind of reduce the anxiety, some people that can take, more than an hour a day, 2, 3 hours that they're engaged in a lot of these behaviors. So you can imagine how much time that sort of takes out.
Yeah, and then the consequence of that is people who just want to avoid those situations altogether. Like, just to continue this example, if someone had obsessions and compulsions about driving, someone who is very nervous to drive and takes all these other alternatives around driving, and that's impairing as well. That avoidance behavior can be such a easy consequence to fall into.
Yeah, I think, you often see when sort of that anxiety comes up, there's sort of that some of the behaviors will kind of then fall under that avoidance category where it's sort of, maybe if I just don't drive, then I don't have to worry about bumps or anything like that. And then I don't have to deal with those thoughts coming into my mind. And then other times it can be hard to avoid stuff. So, as an example, if somebody's leaving the house and they have the thought, did I lock the door? It's hard. I mean, I suppose if you just never leave the house, you might be able to avoid it. But otherwise, you sort of get stuck in a position where you have to check. And that's another one of those examples where sometimes people know that they've locked the door because they've now checked it 2, 3 times, but that thought just keeps recurring. Maybe it's open, or maybe when you checked it, it unlocked itself or something like that. And then people feel the need to go back over and over and over. So right then, as an example, like leaving the house could take 30 minutes with all of that checking involved.
And I think that's describing it in that detail, I think is so helpful to distinguish it from organizationalness or conscientiousness. Like, just as an example, um, I have a lot of family members on my mom's side are just conscientious by nature. So upon leaving the house, check everything's off in the oven twice, check all the doors are locked twice, make sure the door's locked every time. No one has OCD, and that's just a personality trait. So how would you distinguish that as a clinician?
Yeah, I mean, I think it's kind of comes down to like the level of impairment. Cause I mean, there's also like a certain reasonableness. Like if you've been using the stove and you're going to leave the house, it's probably not a bad idea to check it. Or, lock your door. It's not a bad idea just to give it a tug to make sure that it's actually locked. And if you do that twice, it takes a couple of minutes. It doesn't take that long. And so, people are probably able to move on with their day pretty quickly. So like a couple checks doesn't usually impair people. It's sort of when it exacerbates to the point where you can't stop thinking about it, or you're stuck in those behaviors for long periods of time. That's where it sort of becomes a problem.
So it's the duration of impairment and the level of distress. Those are the distinguishing factors.
Exactly.
And what do you think is the impact? Because people use OCD pretty colloquially as well. You'll hear that often in conversations. Someone who likes to arrange their pencil case in a certain way. Oh, I'm a little OCD. What do you think is the impact of using that term in that way?
Well, I mean, we all have like our ways of doing things, like as an example, I kind of, if you go into my office, you'll see all the books, they kind of come down in descending order. And if there's one that's not out of place, I like to go and fix it. Again, it takes a few seconds to maybe do that. And so I think a lot of times people throw it around as like, oh, that's so OCD or things like that. But it's more in those cases, it sometimes can be just more of a preference. It takes 2 seconds. There are versions of OCD where people will sort of like things arranged in a certain way, or, if a picture is sort of off center, for example, it will really bother somebody. But I think for a lot of us, when we have those certain things where we like it the way we like it, it's probably either a pretty quick fix or it doesn't cause us that much distress if it's, you know, off in some way. So, I've had people where, if some of the art in the office is a little bit crooked, it can really bother them and distract them to the point it can be really difficult to actually continue on with the session because they become very focused on that idea. Whereas, if I pass the books and there's one out of place, I might notice it and then if I'm busy or something like that, I can probably move on from it and maybe I'll fix it later. But it doesn't cause that same level again of impairment or distress. And, we throw it around like, very easily, that term, I think, and it's sort of being misused because it doesn't have that same obsession, anxiety, compulsion sort of piece, just somebody who's organized or somebody who likes to do things in a certain way. And so I think for people sometimes when they do have OCD and sort of the distress that's caused by it, it can be a little bit invalidating when somebody who just likes their pencil case a certain way is sort of using that term. But I think it can also then, on the flip side of it, using it can also pathologize what's otherwise fairly normal, reasonable behavior.
Yeah, invalidate is a great word. Yeah, I like everything you just said. The pathologizing of it, because people are, especially nowadays, with as great as it is that everyone's talking about mental health, people are quick to self-diagnose, and that can be an injustice to people who actually suffer from the disorder. And then when people mention it, it doesn't have the same impact because it's assumed that everyone has, oh, I'm a little OCD, I'm a little OCD. You have it. That's the same thing. What impact do you think it has on the individuals with OCD just psychologically, just going through life and trying to share this with people, saying, "Hey, I have OCD," and people don't really understand the extent of it. How might that negatively impact them?
I think for some people, if you're trying to sort of express, I've got this condition. And I think most people will understand or sort of understand the more you try to describe it to them. So as you sort of explain what's involved, I think a lot of people might see it in a different light. But if somebody says, oh, I have really bad OCD and, I'm struggling to make it to work today, as an example, somebody who doesn't really understand what that is and is like, "Oh, how can you not make it to work because you have OCD? Like, just, put your pencils the way you like them and, you know, get to work." And so I think for some people when they may not understand that it can actually be quite impairing and distressing and impactful on a person's life. And I think on the flip side, when people sort of do that sort of self-diagnosis, which, I know, you can read a lot of blogs or you can read a lot of, symptoms online and so on. I find it also starts to worry people because they might be doing something that's really not all that uncommon, but it can actually create a lot of anxiety because then they're so worried about the fact that they might have OCD or that they might have this condition that it actually then causes anxiety just by sort of pathologizing otherwise normal behavior.
Yeah, I think I can be sympathetic to that. When I was first diagnosed with ADHD. I remember when I went in to speak with the psychiatrist. I went in I was so sure I had depression, and I went in expecting it. And what was interesting is later she went on and said, "But this is probably best explained by ADHD, correct, etc." But it was an interesting way she articulated it, which is she was going down the list of disorders, and she said, "Don't have this, don't have this, don't have this, don't have this," and she got to the last two, which were ADHD and depression. And she hits depression. She goes, "You're not depressed, but you're certainly sad." I was like, "Oh, could you elaborate?" I was 13. I didn't know what it meant. She goes, "You're sad. I can see it from your answers and from our conversation here, but it's not in a disordered way. It's just kind of an emotion that you seem to be having over the last period of time."
Yeah. I think for a lot of these things exist on a spectrum where
Hmm.
you can be, a little bit sad and kind of for something's happened or maybe, something sad has occurred. And so you're kind of having, again, like a normal emotional reaction. And it's sort of as it kind of goes down that level again of like intensity and level of distress, level of severity. And then at some point, you kind of cross over into depression. So I can kind of understand what you're saying, where like people, they might see like people have these behaviors where they like to, they might need to fix, a piece of art or have things, organized in straight lines or color coded or things like that. And then when they're just doing a little bit of that, it very quickly becomes identified as that's OCD when, it's just sort of it's on that spectrum, but it's probably not to that threshold that it's really causing that distress and impairment.
As a clinician, how does that conversation work? Someone who comes in and says, who isn't yet diagnosed with OCD, and but is just coming in and saying, "I have obsessions, I have compulsions." How do you, as a clinician, kind of have a conversation to be able to separate that from personality, maybe from obsessive compulsive personality disorder, which is another distinction? How does that conversation play out?
So in my practice, I try to use a fairly like a semi-structured diagnostic interview. So really looking at the symptoms and the impairment and how long people are spending on these things. But I'm also looking for sometimes in the description of how people are describing the experience. Because for OCD, I'm really looking for that of intrusiveness in the description and trying to kind of get a sense that it feels like it's sort of intrusive and that it causes that distress or the person really feels compelled to act in a certain way, and if they didn't act in a certain way, that distress would really continue and be quite challenging for them. So I'm looking for sort of those kind of cues to try and distinguish, what is, maybe more of a sort of this isn't OCD versus this is OCD. You mentioned like obsessive compulsive personality disorder. And although they share a similar name, they're quite different in terms of what they look like. So something like obsessive compulsive personality disorder, just shortened as like OCPD, it tends to be that more perfectionistic sort of more a little more rigid, rule-based kind of approach to things, but it's kind of pervasive. Like it's sort of with everything. Like the person might, like a certain level of orderliness across the board, whether it's at work or whether it's at home or whether it's with their personal things or, financial things or whatnot, versus sort of, again, that intrusive quality of sort of like this thought kind of came out of nowhere. People with more of like OCPD, it's sort of almost like that. It's just the way they approach and see the world in a very pervasive kind of way, but it doesn't have that same sort of intrusive quality to the thought process.
Yeah, because personality is throughout your entire day, your life. And so it's going to be throughout your whole life experience and it's going to be independent of the situation. Whereas OCD sounds more situation dependent and there's more specific triggers that are going to set off an impulsion and set off that.
Yeah, that's a good way of phrasing it. Like OCD has more of like there's often is a trigger and there is sort of that thought in the moment. Whereas when you're looking at personality, it's just kind of, your way of often viewing the world in a certain way. And even I just want to put a caveat in, like even when people have like more of like an if we call it like an obsessive compulsive personality, that also isn't a bad thing in the sense that, people who are organized and who are kind of very driven and so on tend to do very well for themselves. And again, that notion of it becoming a personality disorder, that's again where we're getting to the point where things are starting to get in the way. So, that style is causing a lot of conflict at work or it's causing relationship problems or whatnot. So even just having sort of a very organized kind of, sometimes you can almost think of it as like a type A kind of personality. It's not a bad thing. It's just when so not a problem until it becomes a problem, I guess you could say.
I just want to spend a little more time on, you mentioned the relationship with people, relationships at work. How do you find OCD negatively impacts people's interpersonal relationships, whether that be romantic, friends, family, professional settings, etc.?
It often depends on the sort of well, I don't want to say the type of OCD, but sort of what the focus of the OCD sort of is. But oftentimes, if it's something that the person needs to maybe regularly do, or if it's something, let's say, would really, if other people didn't do it a certain way, it would really bother them. So if we think about, as an example, like when people have OCD with like cleanliness. So you can imagine, for example, when we had COVID, a lot of people were very triggered by that. And so they may have certain routines around hand washing or sanitizing when you come in or, changing your clothes at the door or so on. So if you're living with someone and they don't think it's necessary, for example, to change their clothes, or they don't really see the need to wash their hands again in the house after they've already, let's say, sanitized coming in. For the person who has OCD, the fact that they didn't do that can cause a lot of anxiety. And so that can create a lot of conflict because one person is saying, I really need you to do this because it's causing me so much distress if you don't, change your clothes at the door. And the other person is saying, that's very burdensome for me and I don't think it's necessary. And so I don't want to change my clothes at the door. And then it becomes sort of how do you resolve that discrepancy in views?
You approach that as a clinician in those situations where it's another individual's behavior that they're taking issue with.
So in a sense, like if the other person was sort of the client
Yes, yes, yes. So
or if the OCD was kind of having like with the other person's behavior.
the person with OCD is in your office and they're saying, God, my partner only washes their hands the one time. It's freaking me out.
So, from like a CBT angle, we're often trying to look at reducing the compulsive behaviors and trying to align it with sort of what would be sort of typical best practices, I guess. Like, because you do want to wash your hands in certain circumstances and you do want to wash them for a certain amount of time because, that's, just part of just, good hygiene and so on. So we would try to kind of bring it to more of like an evidence-based sort of behavioral, like if they say, you don't need to change your clothes as an example, like if that's sort of the advice that's out there and the medical advice and so on, we'd probably try to get the person who's suffering from OCD to get comfortable with not changing clothes when they come in the house and being okay or be eventually, reducing the anxiety when somebody else does that as well. So we'd be trying to kind of move the behavior because the trouble with OCD is that, and this sort of applies to most kind of anxiety, is that when you engage in the compulsive behavior and it reduces your anxiety in that moment, that negatively reinforces the behavior. So that actually increases it in the long run. Often with OCD, you do have to work with partners or family members or whatnot because you don't want them to inadvertently also reinforce the behaviors through their behavior. So it usually is about trying to sort of remove some of those behaviors. And similarly, so the conversation, the person with OCD would be like, if we identify that as a compulsion, the idea is to get to a place where they're okay with not changing their clothes when they come in. And similarly, they're then okay with their partner not changing. I wouldn't want to go the other way and encourage the partner to say, okay, well, it really bugs them. So would you mind just like changing your clothes for the next few months? Because that's going to reinforce it and that's going to make the OCD worse rather than better.
How do you approach breaking that cycle when someone is stuck in that place of where they're really committed to their behaviors and it's getting enforced by the people around them and they might be engaging in some avoidance that's reinforcing it more? How do you break that cycle? Well, you mentioned the evidence-based.
Yeah, I think there's a couple ways, like there's a couple things. I think first of all, you need that buy-in in the sense of often, starting sometimes with some cognitive strategies to sort of look at, whether those behaviors are, evidence-based themselves. Like, are these things that you need to really be doing? So if somebody, let's say, washes their hands on a very, let's say very frequent basis and washes them for 5 minutes such that, their hands are cracking and dry and so on because of all the hand washing, it's sort of part of it's a discussion around, do you really think you need to be washing for 5 minutes? If you have that buy-in, then what we would normally try and do is do some exposure, technical terms, exposure and response prevention, to put people in situations that will activate the anxiety, but then prevent them from doing the behavior. So somebody, let's say, might touch a door handle, and then instead of washing their hands for 5 minutes, we see if you can only wash it for 4 minutes. And then we do that a bunch of times as the person gets more comfortable with that. Then we might say, okay, can we bring that down to 3 minutes and then 2 minutes and then 1 minute and then 30 seconds? And then maybe we change it from a door handle and then we say, you touched a subway pole. Could you then, you know, can we do that again? If you were to flush a toilet in a public building and you've touched that, can we bring that down to, let's say, 30 seconds eventually of hand washing? So the idea would be to expose the person to the trigger, and then over time and through the repetition, the anxiety eventually comes down. And we usually try to start at sort of a low to moderate intensity. We don't want to overwhelm people and start with like the worst case scenario, but eventually we do want to kind of work our way up to harder and harder situations. And then eventually the anxiety starts to dissipate and then the thoughts start to come less and they're less intense and you can let go of them a little bit easier. The tricky part is sometimes when somebody doesn't have that buy-in and they're like, no, I think that I should wash my hands for 5 minutes. That seems very reasonable to me. And I don't really want to change that. And then we might be sort of doing more sort of questions around like, well, so is this really working for you though? So if your hands are cracked and dry, if they're bleeding, if they're at risk for maybe potential infection because there's, breaks in the skin, if it's taking a lot of time out of your day, if your workplace is sort of saying like, disappear regularly for, 5, 10 minutes and, you're falling behind on your work. We sort of want to look at, is it working and is it worth then maybe trying it a bit?
Mm. And I find that buy-in so interesting because that is a challenge that seems to be, I don't know about unique, but it's experienced in psychology and not very much in other fields. Like an optometrist, the patient doesn't come in and an optometrist doesn't have to convince the patient eyeballs exist. And that's not a dance that needs to happen. So how do you manage that as a clinician? Someone who comes in and they're like and they're just like, no, 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 this is and then you have to kind of bring in that evidence. And how do you present that in a way that gets them to accept, okay, maybe not 5 minutes.
Well, I think it's all an individual choice. Like the way I try to look at it is, everybody has different ways in which they choose to live their lives or they want to live their lives on the basis of their values and how they grew up and so on. And so I try never to impose sort of my view onto them. So, you know, if I think like, oh, okay, like, 30 seconds is probably fine. And they're saying, no, no, I think it's 5 minutes. I don't ever want to impose sort of, I think it should be this or, the research says it should be this or anything like that. I kind of want to have more of a discussion because whenever you want to make change in your life, it really has to be something that you believe in and that you sort of think is in your best interest and is going to work for you and it's aligned with kind of what you. And so it's often a discussion just to kind of see, what are the benefits perhaps of continuing the behavior and washing for 5 minutes and what are some of the drawbacks and also looking at, do you have concerns like some people they worry like if I didn't wash that much maybe I would get really sick, and so trying to address some of those concerns around behavioral change as well, and then at the end of the day it's up to the person to decide if that's the route they want to go.
And then it's also, yeah, it's a challenge as well when people are just in those situations they where there's all these triggers there's all these triggers around them and they don't know how to they're not willing to go into that and they develop this avoidance. Can you explain how that kind of can formulate when someone is starts to develop avoidance behaviors and they start maybe trying to work from home instead of going into work and needing to wash their hands all the time with that example? How does that kind of develop?
So it often has a bit of like a slower start initially. Often what happens is, I sort of use this example when I'm trying to describe, OCD to some of my clients. So it's kind of like if you were walking down the street and you saw like a really yappy dog. In that moment, you're going to have tons of different thoughts. You're probably going to have thoughts of like, wow, that dog is annoying, or also, wow, that dog is cute, or, I'm glad I'm not that dog's owner, or I want chicken for dinner. Like it can be all sorts of thoughts. Somewhere in there, somebody might have the thought, kick the dog. And because it's a bit of an unusual thought, sometimes it can get a little bit hooked. And people will often ascribe meaning to the experience of having that thought. So somebody without OCD might just sort of be like, oh, that was weird. And they just kind of continue walking down the street and sort of let the thought go. But often in the cases of OCD, there's a meaning that's sort of made about the thought. So it might be like, does that mean like I have these tendencies that I never knew about? Does that mean I might just lose control of myself and suddenly kick a dog? And if we're talking about a dog, could I do that with another person? Could I do that with my kids? And so that's how the anxiety starts to build. And as various things sort of trigger them. So, for example, if now they're sitting at home and they're watching, a movie that let's say has some violence in it, they that might trigger them because they now might have the thought, you're going to punch the person sitting next to you. And that thought just kind of pops in their head. So as a result, they may turn the movie off. Or if they think like, oh, if I have the thought, I might sort of just lose control, they might sit on their hands. They might move further away from the person. And what that does in that moment, as we were saying earlier, that kind of creates a bit of that relief. So now I've gone from one couch to the other, so now I can't sort of just swat them, uncontrollably. So I feel better. But what that does is it kind of does a couple of things. There's sort of that negative reinforcement of the behavior. So that means next time that I'm watching a movie, I'll probably start on the other couch. And then maybe I end up further away. And then maybe I won't watch that movie with that person at all. So the behaviors can start to escalate. But there's also a little bit of like an implicit validation, because if I'm sitting on a couch next to somebody and I suddenly feel the need to get up and go to another couch, it sort of almost validates that idea that maybe I would have lost control and just hit them in the face. Because otherwise, why did I move? So it almost validates the veracity of the thoughts, which then can also increase the anxiety as well. And so as the anxiety goes up, the behaviors start to become more impairing. So it's not uncommon that people will say to me, like, yeah, it just started with, a couple checks of the door and a couple checks of the stove or things like that. And now it's, I have a whole routine that I have to do that takes half an hour before I can actually leave the house. But it might have just started sometimes with a few checks.
And it sounds like a lot of, just in those descriptions, it sounds like a lot of time spent thinking like thinking the worst of yourself. Which I think is because you're spending a lot of time thinking, you're walking down the street, you're like, oh my God, am I violent to animals? What if I'm violent to animals? You're on the couch, you're like, am I gonna hurt my friend? It sounds like you're spending a lot of time thinking very negatively about yourself and what you might and what your behaviors might be. Does that sound accurate to you?
Yeah, I mean, when the anxiety is sort of activated, and then the things that make us anxious are usually more those worst case scenarios. So, if you walk down the street and you have that thought, I should kick the dog, and your response to that in your head is, well, I don't think I will, or that was strange. Let me just keep on walking. Doesn't mean anything about me. Then you're not going to get anxious, and then you don't kind of go down that cycle. But it almost becomes sometimes people will say, like, the act of even having had the thought. Like, why would I have had it if I'm not that kind of a person? Or why would I even have it if it wasn't meaningful in some way? Like, why would I keep thinking the door is unlocked if it wasn't? So there must be something going on with the door. So again, we can even just make meaning of the act of sort of having that thought. And then that anxiety is usually triggered by those worst case scenario interpretations.
And that's a lot of really believing and spending a lot of time about thinking about your own thoughts and a lot of time believing the worst things that your brain is conjuring up in these you know, in these moments. How would you recommend to someone that they approach these kind of situations where they're experiencing these triggers? How would you recommend someone in the moment that they learn to manage that thought?
So from like a CBT kind of lens, there's a couple of ways you can sort of approach it. From a cognitive side, I often think about sort of trying to pause on the thought and then sort of trying to critically examine or evaluate if it's accurate. So if I have the thought that I'm going to, lose control and kick somebody as a result of the thought that I have in my head, we can sort of look at that and do sort of an analysis of whether that thought is actually accurate. Have you ever had a thought before of like, you're getting angry at someone and you just kind of had a thought of pushing them, but then you never did. Do does the act of having a thought mean that you're going to react in a particular way? And so then we can look at people's examples in their life to try to bring up evidence and sort of see, like, if the person says, yeah, I've gotten mad at people before. Like, I've had, people cut me off in traffic and I have the thought of like, going around them and brake checking them, but I never do it. Those are examples of how your thoughts don't necessarily translate into behavior. And so if we can find those examples, then in that moment, there could be sort of a reminder of like, that's not accurate. I'm not going to kick that dog. I'm not going to hit that person because I'd never done that before. So there's sort of the idea of looking for evidence. And then the other part cognitively you can also try is sometimes a little bit of externalizing. Like I sort of mentioned, like, those thoughts are kind of ego dystonic, which means the person gets distressed by them because they don't want to kick the dog. They don't want to hit that person. They don't want sort of the door to be left open. And there's sort of this way of trying to maybe label that as this is my OCD talking right now. That's not me. Like that is an external thought, and I don't have to necessarily pay attention to it just because I had it. So if you have the thought, the door is unlocked, that can also be kind of like a decision point, like a fork in the road. And say, like, if I label that is my OCD, then you can choose to act in a way that's in accordance with sort of what you think, which is sort of like, I know the door is unlocked. That's my OCD telling me, or I know the door is locked. That's my OCD that's telling me that it's unlocked. And trying to kind of bring your attention and then align your behavior with what you believe or you kind of know to be true, not sort of what the OCD is necessarily telling you. So there's a bit of externalizing and redirection of attention that can also be helpful as well.
One of the pieces of mental health advice that I received, and I've passed it on to other people who are dealing with similar situations, is there was a phrase my would often get thrown around in my household, which is your brain is not your friend. And I think that's so helpful to distinguish you from your brain because you are your own, and these thoughts that you're having or these emotions that you're experiencing is to separate that from yourself in some way. And that kind of sounds like the same thing. And I think that's a really great way to phrase it, externalizing, to kind of keep this outside of yourself, I think is so helpful to create a separation between yourself and these thoughts, especially when someone feels like these thoughts are attacking them.
Yeah, and I think that I often will say that to people where sort of tell them like, this is kind of what your brain does. So for whatever reason, and there's a number of reasons, why people have OCD, although it's not entirely fully understood, but there are some genetic components and some biological components and environmental components. But I often sort of think of it as like, however we ended up here, this is how your brain works. And so and that also, this kind of goes into also the treatment goals as well, because then it's not necessarily about never having an intrusive thought again, because we all have them. Everybody has intrusive thoughts all the time. And some people's brains just may generate more intrusive thoughts than other people's brains. The key almost becomes, how do I relate to those thoughts? So if this is what my brain does, can I sort of find a different road? Because my brain is going to give me this thought and that thought's going to make me anxious. But then because I can control what I pay attention to. I can control my behavior. I can control how I handle those thoughts when they come into my head. And so that, again, that separation can sort of be a good starting point to kind of get people a little bit unhooked from the OCD.
And that's the treatment. Yeah. I really like how you phrase the treatment goals because the goal in therapy, regardless of technique, isn't to cure you. That's not going to be the objective. It's understanding here's how your mind works and if the approaches you're taking, if it helps to know kind of how that developed, but the ability to know how to manage it and how to regulate it yourself. And in this case, it sounds like knowing how to kind of use yourself as evidence and that examples of similar scenarios and where you didn't act in the way that your impulse is telling you that you might, and then knowing how to externalize and knowing to do that in the moment to suppress that thought without having to engage in that consequential behavior.
And I might say it's not even about suppressing the thought. That's an interesting part about OCD as well, is that a lot of times people do try to suppress it. And I describe it to people as like, it's like trying to push a beach ball underwater. If you try to push it away, you have to spend a lot of energy and time sort of holding that beach ball down there. And the second you break your attention or you move your hand, not only does the beach ball come up to the surface of the water, it probably pops out and hits you in the face. And so there's a lot of times where people will sort of try to be like, don't think about that. Don't sort of go there. And that can actually also make it worse. It's sort of like telling somebody, don't think about a pink elephant. You're going to start thinking about a pink elephant. So part of it is really sort of acknowledging that the thought is there and being like, yep, there it is again. That's my OCD thought that just came in. And not trying to push it away, but it's sort of about how do we sort of have it more peripheral rather than kind of right in front of our face. So we don't try to push it, like suppress it, but it's about acknowledging it, but maybe not giving it a lot of airtime in your mind.
Just being able to accept that it's going to be here and just being able to put it to the side and not give it that disordered amount of attention.
Yeah, not give it that weight that it's like, yep, that's another OCD thought and moving on with my day.
Hmm. Yeah, just yeah, that ability to acknowledge in the moment is so helpful, just to kind of compartmentalize that and being able to move on. It just the last one of the last thoughts I want to talk about here is how do you in the moment, how do you tell someone if someone has the attitude that they really want to suppress it, how would you recommend they learn to not resist that and just kind of accept that, okay, this is how your brain works when someone's very, very committed to the kind of resistance, that beach ball pushing approach?
So, what we sort of know from the research is that, especially with OCD, exposure is kind of the gold standard piece of it. And so, whether that's behavioral exposure, like we talked about before, and kind of escalating the behaviors, but also cognitive exposure to it. So, the idea is kind of even if that thought then becomes distressing to you, it's still about exposing yourself to it and facing it rather than avoiding it, because that's really what the suppression is. And you can almost look at it, if we really wanted to put it in an OCD model, the act of suppression could just be thought of as a mental compulsion. It's just another thing you're doing to try and reduce the anxiety. And so if we think about it in the context of whether it's behavioral exposure or more of a cognitive exposure, the idea is not to avoid, not to do stuff that's going to sort of try to reduce the anxiety in the moment. It's kind of to confront it head on and sort of ride that wave of anxiety ultimately. And so I think if people sort of can understand how the model works, and so when I'm working with people, I usually try to draw it out for people and kind of show them how all of this works. And that's where that avoidance becomes so important to avoid. So whether it's a behavior that people are doing, whether it's I stop watching those movies, or whether it's I try to suppress those thoughts, those can all be thought of under that compulsion.
So that's great that how compartmentalized and how specific those examples, those treatment examples are. That's exactly what I was looking for from this discussion, was to kind of bring out very clearly what it is and what it isn't, what the experience is like, and just very clear examples on how to deal with that. Just to end off here, is there one piece of mental health advice or just life advice you would give to someone who's dealing with OCD?
It's going to sound kind of cheesy when I say it, but you're not alone in dealing with it. There are a lot of people out there, but more importantly, who sort of successfully learn to navigate and manage it with the right tools and can really get to a point where the distress is not impairing any longer. And so there is hope. The treatment, typically works fairly well. There's good evidence for it. And so there is a way out.
I love how you phrase that, because I find that when people say that they have this, they're dealing with, whatever it may be mental health wise, and people say you're not alone, the reaction commonly can be, great, a bunch of other people are sad. How does this help? But to phrase it in that way, it's that you're not alone in this, and a lot of these other people, the treatment has worked and they've gotten through it. That's a very different message, and I think that's so much more positive and motivational. That's great. All right. I think we've hit all the checklist for today on what we kind of sought out to cover. I think we got some good information out.
Excellent.
All right. Thank you so much for your time today. I think we've had a really positive discussion. I think we went above what message I thought we were going to get out there. So thank you very much.
Yeah, my pleasure. Thanks for having me.
Thank you. All right.